All right. Okay, let's see how we're doing here. Not so good. So, as I just mentioned, we're going to be covering these two chapters, and there's going to be a lot of information that we've already had in there. So we're just going to refine it just a little bit for these particular populations. So it's not as bad as it looks. Except I can't get this thing to work. Okay, geriatric emergencies. As I said earlier, at the first of the semester, a large percentage of your patient population is going to be older people. So we're usually, typically over age 65, but we're seeing younger people that are very ill. So we're looking at things that are specific to the elderly population. They're going to present a little bit differently than somebody that's, say, 25 or 30 with the same disorder. We're also going to talk about how to communicate specifically with older people. Just because they're old, it doesn't mean they can't hear, doesn't mean they can't see, it doesn't mean that they don't know exactly what you're talking about. But sometimes we may have to communicate with them on a little bit differently. We're going to look at doing assessments and providing care for your elderly population, because they are going to be a little bit different. We're going to look at specific injuries and illnesses that we see with the older population, not quite so much as we do with the younger people. What's the difference between a chronic disease and an acute disease? What's chronic? Chronic is something that's over a longer period of time, whereas acute is going to be what? A fast onset. And these are a little bit relative. Sometimes you may be talking about something that's chronic. You have a chronic cough and it's been going on for 3 weeks. Well, that's not really a chronic cough, so to speak. Different than if I started choking on, something I ate, which would be acute. So an acute illness may be worsened during an underlying chronic illness. So a lot of your older people, your older patients may have a chronic illness that either has an acute exacerbation, which means that illness has gotten much worse. So, for instance, asthma, you may think of asthma as a chronic illness, but you have an acute attack, which would be an acute exacerbation of that. Same thing with something like COPD. They chronically have COPD, but for some reason something has stimulated that and caused it to go into an acute stage fairly quickly. So we have a lot of patients, I mentioned, that have chronic diseases, but patients are living a lot longer. 100 years ago, the average, age of death was like 45 to 50. Well, not so much anymore. Patients are living to their 80s and 90s. I told you Tim's mother is like 93 or something. So they're living a lot longer. Consequently, they're not living as healthy. The patients that died, the people that died at 45 and 50, 100 years ago, what do you think was their most likely cause of death, or a significant portion of that?
Accidents?
Yeah, probably accidents and trauma, and they shot themselves while they were out hunting for bear or whatever. So a lot of those types of things. And then illnesses that we take antibiotics for now, used to just like kill them on the spot. Well, now we are surviving those. Also mentioned early in the semester about how we age. Do you remember I told you what percentage of our body system's functioning do we lose every year after age 30? About 1 what? 1%. Yeah, did I say it as percent? 1%. So all of your elderly patients, even your most healthy elderly patients, are still going to have some age related degeneration. Their maximum heart rate declines. So that's important because, say for a guy that's 25 years old, you may be able to tack along at 220 easily. But for your 80-year-old, not so much. 180 or 170 may be their top possible heart rate. The heart rate just can't do it. So you're going to have to factor that in too. When you have a patient that possibly has some internal bleeding, they're going to become shocky faster because their systems aren't as efficient, as healthy as younger patients. But since their heart rate can't go as high, it may not show itself as being tachycardic because it just is not able to do that much. So if you become shocky, you might be tacking along at 140, 150, Whereas an elderly person, 100 might be what they do. That may be all they can muster. So you can't specifically look at some of the parameters that we set for pretty much our healthy population. What's another thing that could cause a elderly person from not showing the typical signs of shock? So, that's possible. How would you determine that? Yeah, what do you want to find out specifically? Yeah, what's norm? You know, is this different or is this their chronic normalness here? As far as a heart rate, they may have a low heart rate anyway because, yeah, well, not necessarily they're old, but they may be on medications that keep their heart rate low. It's cardiac medications. They may have a pacemaker that's set at a certain amount, and it's really not going to go over that. So they may have reasons that they're not going to become tachycardic, but they could be shocky. So when we look at the normal things that would cause a patient, the normal signs and symptoms that we would look for that may indicate shock, isn't heart rate one of them? Yeah, I mean, would you suspect shock if you got a patient with a heart rate of 85? Probably not. So what other things might you look for? Yeah, then the next thing we check is going to be blood pressure. Well, you know, they may have chronically low blood pressure, for one, their heart's not functioning well, but they may be on medications that keeps their blood pressure down. So they may not show those typical signs and symptoms that we may look for, vital sign-wise. So what other things might you look for? If you can't rely on heart rate, you can't rely on blood pressure. They look at skin signs, yeah. Do they look, what would you be looking for there? Are they pale? Do you see elderly patients that are pale?
Yes.
Sure. So what else about skin signs then? Would you want them to be jaundice? Would that indicate shock? Yeah, I'm going to start looking for cyanosis, probably more than just about anything, and then altered mental status. You know, if it's an acute onset of altered mental status, then shock may be something I'll look directly at. If they always have an altered mental status, is that altered mental status going to really help you? Only if it's different than their normal altered mental status. Does that make sense? How different is it? Communicating with older patients, it can be difficult for a lot of reasons. What can make communication with an elderly person difficult? They don't hear well. They may have speech issues. They can't speak real well. What could cause them to not be able to speak well? If they've had a stroke, certainly. If they've got missing teeth, they've got dental hygiene issues. What other things might interfere with communication? They what? Sure, they may have a tracheostomy, so they may not be able to speak that way. That's a possibility. Yeah, if they have a chronically altered mental status, which is their normal state, then they may have some difficulty communicating. Can you think of anything that's not physiological? Now, you guys may not notice this, but I notice it sometimes, that generational gap between language is it can be very challenging for your older population. You know, you're used to saying certain words, they use different words, you know what I'm saying? It's kind of like, sometimes I would have a very difficult time trying to read some of your written communication if you're writing it like you text. It's like, I'm not sure what that means. So, yeah, you may get some changes like that. They may also have some memory issues. They have a hard time holding a thought, which I have sometimes. They sometimes confuse things. They can't remember if it happened 30 minutes ago or if it happened 2 hours ago. Can't remember if I took that medication or not, that sort of thing. And this is not for everybody, but you may have patients that this is a challenge. First, assume altered mental status is a result of something present. And probably more times than not, an altered mental status is going to be an acute onset. You're going to have some patients that have some kind of dementia or other issues of that sort, but more commonly, you're going to find it's acute onset. So don't automatically assume, well, they've got dementia. They're just not getting this. Make the assumption on the other side of that there is something acute, that there is a medical or trauma issue causing that altered mental status. Make sure you do a good scene size up. What all are you looking for in a scene size up? If you have a call, a medical call, and you respond and it's an elderly man back in his den. So you're looking to see if there's medication standing around. What else are you looking for? They're what? Yeah, are there any trip hazards? Maybe they've fallen and hit their head or something. What else are you looking for? Yeah, is it warm? Is it cold? Is it the temperature that you would expect to find in somebody's home given the circumstances? What if it's 90 degrees outside and it's 110 inside? Can you see that as a problem? Can that help you with your assessment of your patient? Sure. What else does it tell you about your patient? They're cold natured. Very funny, though. They're cold natured. It's 110 inside. They may have financial issues. They need somebody checking on them, and that's not happening. They could have some malfunctioning, equipment there that's preventing them, having air conditioning on or whatever. But that's very important to your scene size up. It's very important to your assessment. Now you know you've got a patient that's not being cared for properly. So in that setting, that's no different than, a pregnant female that goes 9 months and she's never been to the doctor. We'll talk about that next week. That's going to send little alarms off that you may have a problem delivery there. So when you see that, you've got other problems besides just this acute problem with your patient. So make sure that your scene is safe, of course. Remember last week we were talking about potential suicides or what age group of people commit suicide? Mm-hmm. So you got to think about scene safety here too. If you've got an altered mental status, you're responding to an elderly patient, you do want to think about that. You'll still do your primary assessment. You'll do your secondary assessment as with all of your patients. We already talked about this. One of the things you want to look for too is the overall health of your patient is, are they eating right? Sometimes you walk in and there may be, I think we talked about this, fecal matter, where they've got a lot of pets and they're not taking care of the pets properly. You may see stacked up dishes in the kitchen or just laying all around. They may have 3 days worth of food gathered around their little TV tray by their chair. All that's going to let you know that there's some definite care issues there. Is the house dirty or clean? And you'll get to know the difference. You'll walk into an elderly couple's home and it's neat as a pin. It doesn't smell bad. You can tell that somebody there is taking care of the inhabitants. And the flip side of that is you'll see where no one's taking care of the people that live there. You'll still do your general impression. A large part of your general impression is going to be really the environment. That's going to tell you so much about what you expect to find with your patient. Mental status, ABCs, all the things that you already know. This should be respiratory here. When we look at the different body systems, we're going to see changes that are specific to those body systems. When we talk about every system in the body decreases 1% per year over age 30, then even the normal, most healthy patients are going to have deterioration. So we're going to look at some of the things that you may expect to find system-wise. Your elderly patients are not able to take those really big breaths anymore. They don't have the muscle strength in between the ribs that they used to have. The lungs are not as functional as they were. They have a loss of the smooth muscle fibers. What specifically are these? Smooth muscle fibers, we're talking about the respiratory. We're talking about respiratory. Your what? Here, smooth muscles, usually we're talking, in the respiratory tract, you're looking at your bronchi, your bronchioles. All of those have smooth muscle and they expand and contract, right? So if you have a decrease in those, that's going to interfere with your normal respiratory. If you take a deep breath because you need more air, but your smooth muscles, you don't have enough to cause that dilation, then it can be a problem. They have a diminished cough reflex. They can't cough and clear you'll notice that a lot of your elderly patients, they get a lot of mucus up. When you auscultate, you'll hear rales and rhonchi sometimes, and the patient is not really sick. It's because they have a hard time clearing their lungs. They have a decrease in the number of cilia, which is the little hairs that help move all that crud up from your lungs. And I know that's something you've all experienced. You know, you go outside and there's, you know, a lot of pollution in the air, and then you come in and you go, yeah, I got stuff, and you clear that stuff. Well, a lot of these patients are not able to clear that. So what's going to happen consequently because of not being able to clear all that stuff from your lungs? They're going to get sick. They're going to get infections, certainly. Their ribs also, they'll get calcium deposits around the connection to the sternum, and that's going to interfere with that expansion and contraction when they're trying to breathe. It kind of turns them into something, instead of movable, it becomes a solid object, the chest. So they don't have that chest expansion. Without good chest expansion, what's going to happen? They can't breathe really well, they can't take deep breaths, but they also increase their risk for pneumonia. Okay, making decisions about who your priority patients are. Most of the time, this is going to come as a result of history. Unless you walk in and you look at them and you think, oh my gosh, FTD. If you look at them and they look really scary, then you know that you need to move very quickly. But more times than not, it's going to be based on history. You know, when you're asking the questions, and this really is over a lot of your patients, you need to take the time with your elderly patients and get the best information that you possibly can. Now, I've told you before, besides, you know, their body systems breaking down, that's going to include their brains too. The synapses just don't fire as quickly as they used to. They need to stop. They need to think about what you're asking them. You know, you guys, you're used to going back and forth with your friends like this, but when you talk to some 85-year-old guy and you're asking him about, you know, his cardiac history, he's got to stop and think. He's got to process that. He's got to figure out what you're asking. And then he may have to call back a lot of memories. Yeah, I had open heart surgery when I was 65. That was 20 years ago. You know, so that's kind of a stretch for him. So they're going to be trying to retrieve information that's buried in the deepest, darkest recesses of their mind. So you're going to have to be patient with your patients and give them time to formulate their answers. Find out whether the patient is compliant with their medical advice. And you're going to get that group of elderly that do everything the doctor tells them, and then you're going to get that group that goes, he's 35 years old. What does he know? You know? I mean, I was a senior citizen before he was born, sort of. So some of them are going to be compliant, some are not. So try to find out if they're doing what their doctor, are you taking your medications like you're supposed to? You know, are you doing this and that your doctor advised you to do? If you got family members around, try to get some information from them. But recognize that your patient is going to be the source of your best information unless they have an altered mental status. But I don't like it when I hear the medic start asking a bunch of questions to the family and the guy's sitting right there and he's fully capable of answering. So always direct your questions and your interview to the patient until the point comes where you realize he's not a reliable historian. If he can't give you good answers, then yeah, say, ask a family member if they can provide some input. But always start with the patient and keep with the patient until you recognize that he's not all there. After you do your good interview, then you'll move to your physical exam. How are you going to determine if you're going to do a focused exam or just a detailed physical exam? Based on your chief complaint. If he says he hurts all over, you hear that a lot. We're going to do a whole detailed exam, right? If he says, my chest hurts, would that be a focused exam? Yeah, we're going to find out what's going on with your chest. I'm not going to look at your toenails and stuff or look in your ears. You're going to get your baseline set of vital signs. Now, y'all, we're going to be working on our medical assessment, our trauma assessment in lab because we've only got 3 more labs. I looked at that the other day. I was like, oh, 3 more labs. So That last lab, you're checking off on medical and trauma assessment. In fact, I hope that you should be able to check off on your trauma assessment next week. That's going to be my hope. And then the week after, your medical assessment. Notice on both of those, vital signs really comes pretty late in the sheet. Now, that doesn't mean that when you've got a live patient, when you're out there working, that you need to wait to get your vital signs. If you've got somebody else available that can get your vital signs, get them in there and get them to get it, as soon as possible. But you're not going to stop what you're doing to get vital signs at that point. Both of the sheets, the vital signs are a little bit later. Other things, the brain decreases in size. I hate that part. Mass decreases, weight decreases. They have a decrease in cerebral spinal fluid. And why is that important? Think about what all cerebral spinal fluid does for you. What do you think, John? Cerebral spinal fluid? We're talking about cerebral spinal fluid? When you have a decrease in cerebral spinal fluid, it certainly has the chemical impact, but it also, you have a decrease in the cushioning that's provided there.
Is that why they hunch?
No, that is a spinal issue, but it's not cerebral spinal fluid. When they don't have that much, it's not all padding, but it is a little cushioning around the brain, then you're going to run a greater risk of brain injuries, don't you think? As the brain decreases in mass, does the skull have an equal decrease in mass or size? No, it doesn't. So now you've got something smaller in there. There's more space to move around, right? It's just like your little kids. They've got that big skull and still a little brain until the brain grows into it. And then when you get older, the opposite happens. You start out in diapers, you end up in diapers, kind of thing. So there's a lot of analogies there that you'll find between these two populations. So yeah, you have a greater risk of head injuries because of this. Older people also frequently have a decreased awareness of being thirsty or feeling pain or being hungry. Their taste buds have diminished. The taste buds themselves, but they're not sensitive anymore. Their sense of smell is not very sensitive. So, I don't know about you guys, I smell an apple pie cooking in my kitchen. I can devour the whole thing in one setting. Who can't? But if I don't smell it, it doesn't stimulate that desire to eat it. So you'll find that a lot of them lose weight because they don't feel like eating. They don't feel really thirsty. They have those types of issues. Sometimes I wish I had those. They have diminished sensory perception. Their sense of touch is not as clearly defined. As I mentioned, they can't smell. Hot and cold, not so much. They also lose that ability to thermoregulate. Why do they have a harder time keeping themselves warm? Do what? Well, less fat, that may be part of it. Do what? The blood's decreased muscle mass, certainly. Decreased muscle mass, because where does our body heat come from? Muscles, right. Diminished ability to see. A lot of these patients have glaucoma, cataracts. One thing about cataracts, they come on kind of slowly. So the patient just has a gradually diminishing sense of loss of sight. And it's so gradual, they may not even recognize it. They just kind of slowly go blind. If you've ever had a patient that's just come out of cataract surgery, they're going, oh my gosh, I didn't know how bad my vision was. So they may not even recognize that they have cataracts. But you'll recognize it because you'll look in their eyes. And it can be difficult for you to check pupils on some patients because they have this kind of cloud, looks like a membrane over the eyes. Glaucoma may damage the optic nerves. I know you've heard of macular degeneration, where the patient loses their central vision and it slowly works its way out. And then retinal detachment. Have y'all ever known anybody that's had their detached retina? You haven't had that?
No, I've had two cousins go blind because of freak accident.
Oh, really? Retinal detachment is not that unusual. It is a acute emergency. They need to have that thing fixed pretty rapidly or they'll lose their vision. Neuropathy is something that's very common in your older patients. Neuropathy is going to be an issue with the nervous system. We see it frequently with your diabetic patients where they have peripheral neuropathy where the nerves really have died or they're damaged It may feel, it may be very painful, or it may feel numb, it may be weak, but it's usually in the peripheral areas. It may work its way up the legs there. Common in diabetics, but over half of the neuropathy cases, they say, is they're not sure what the problem is there, or the cause. Physical exam. When you're doing your physical exam, you're going to do it just like you do with a physical exam on any of your patients. You'll start at the head and neck, chest, abdomen, extremities, spine. Boy, that was pretty quick, wasn't it? When you're assessing the head, am I missing something here? Y'all don't mind, do you? What different sorts of things you're going to be looking for a head and neck on an elderly patient versus, say, a younger patient? They're probably bruised more quickly. They're probably more prone to bleed. A lot of them probably take aspirin anyway. But when we talk about the other change, the skin thins. They've lost a lot of that tissue that helps protect them. What do we see commonly head and neck wise, otherwise, with these patients? A lot of them you'll find where the vertebrae in the neck are, where they're like this, or they're kind of shaped funny. They may have like the hunchback kind of thing, where you're going to have a difficult time laying them on a long spine board. If you've got a patient, that's got, hunched like this and the head's forward, how are you going to put them on a long spine board? Lots of padding. Yeah, you're going to need to make them comfortable and support that curvature, but don't be surprised to find it. Your elderly population is extremely prone to broken hips, broken pelvis, broken femurs. Here this says the proximal femur. What is that talking about? I think I told you guys this earlier in the semester. A break of the proximal femur. Yep, it's the ball. It's the top part of the femur. Usually the ball is broken. Sometimes they'll call that a femur fracture. They'll call it a hip fracture, but it's really a femur fracture. So falls are extremely common. In fact, falls are the most common traumatic injury that you're going to find with your elderly population. Their bones become more fragile, a lot of calcium loss there, particularly your females. A lot of injuries to the proximal humerus. What are we talking about there? Most of your patients that break, your elderly patients, they'll break this high up at the shoulder here, proximal injury. And oftentimes, they will just splint that in place and they won't even surgically repair it, depending on the age of the patient. Make sure you watch for edema and swelling in the dependent areas. When you see dependent swelling, dependent edema, what's probably the first thing you're going to think about? Congestive heart failure, certainly heart issues. You may also see liver disease causing that. Spine issues, in motor vehicle accidents, they very commonly will injure their spine. I said that, good for me. Part of your reassessment, who would you expect to decompensate more rapidly, a 25-year-old or a 75-year-old? 75-year-old. For the exact reason that we see a 2-year-old compensates very long, right? Because they're very healthy. So they compensate very long and then drop off the planet. Whereas the older they are, the quicker they're going to decompensate. So even though they're compensating now, do not expect that they're going to remain compensating. What is commonly seen when assessing an elderly patient's blood pressure? Huh? They may be hypotensive. They may also be hypertensive. What about pulse? Very commonly, it's irregular. So just because you have an irregular pulse, that doesn't mean anything's wrong with you. A lot of our elderly patients have atrial fibrillation. AFib. So if you find that a patient has an irregular heartbeat, one of the things you want to know about it, if it's is acute or is it chronic? Atrial fibrillation. wonder if I have any answers up here. What is most commonly fractured in elderly female patients? The hip. Yep. What are some challenges you might face in mobilizing elderly patients? I think I already talked about that, right? Problems may present differently in your elderly patients than your younger patients. Can you think of anything specifically? Yeah, with elderly patients sometimes you may get a very general description of what's wrong. Well, can you describe to me how you're feeling? I just feel weak. Okay. Do you hurt anywhere? I hurt all over. Does that mean they're trying to be difficult?
Sometimes.
Well, usually if they're crabby when they're old, they were crabby when they were young. If they're crabby when they're old and they weren't like that, what are you thinking? Yeah, they may have some medical issues there that brings on a personality change. I was thinking specifically here of shock. Remember, we just talked about that at great length. So they may have things that present a little bit differently. You may not recognize it for what it is. Even if you can't recognize what it is, treat everything as if it's something serious because they can deteriorate so quickly. They may present with vague signs or symptoms. They just can't localize it. They've got so many other issues that they can't tell you exactly what it is. So that's very common. Their skin becomes thinner. They have a loss of that subcutaneous layer. So they're losing some of that fatty tissue in there that helps keep them warm, helps to cushion them. They lose a lot of that collagen between the skin that kind of keeps the skin together like it does for younger people. So they're very prone to skin tears and skin injuries.
I have a question. Is that Peter living here?
On her legs. That does look pretty bad. Well, she's broken her ankle.
I've seen her so many times.
Now, she may have had on like some socks, some constricting socks or low hose, and she pulled those off for the picture, and so she's left with that little balloon look. You may see that. Yeah, that's a good catch. Yeah, something like that. Or if they have edema, sometimes, like the pregnant women, I know Brandy, she's had some swelling in her feet, and so her doctor told her, wear some compression socks. She likes that a lot. They have a tendency, I already mentioned that they can get injuries from just you moving them. Sometimes it's difficult to move them from a bed or a chair onto your stretcher without ripping their skin. So you have to be extremely careful with that. If they're laying in bed and they are very elderly and I'm worried about their skin, I'm probably just going to wrap that sheet around them and then just take that sheet with me so you don't have to pull on their skin. They don't perspire very much. When can that be a problem? Yeah, you walk in their house and it's 110 degrees in there and they're not sweating, so they're going to be more prone to what? Hyperthermia, heat stroke, yeah. Because remember, that's going to be the cutoff between heat exhaustion and heat stroke is what? The whole sweat thing. Once they stop sweating, they can't cool themselves. Once they can't cool themselves, body temperature goes up. So for heat stroke, do you have normal body temperature or do you have elevated body temperature? Heat stroke. Elevated. Okay. Now stay with me here. When could a dulled sense of touch be a problem? They what? Yeah, very easily burn themselves. That goes for the tongue. I mean, they eat food that's too hot and they don't recognize it. Medications. This is a really big deal with your elderly population. As I mentioned, sometimes they forget what they've taken or they over-medicate. There's that group of patients, including my mother-in-law, that's, if it's in the medicine cabinet, then I can take it. So they take things that shouldn't be taken together sometimes. Drug interactions, sometimes drug-patient interactions. They're taking things that they don't need to be taking. But there's a lot of side effects of those medications. I don't know if I mentioned this early on, but my mother-in-law, she She was having a problem with diarrhea. Did I mention this to you? Yeah, and it turns out she was taking 5 or 6 different medications that one of the side effects was diarrhea. So sometimes, however they're presenting, it's a side effect of their medication or a combination of taking medications together that they probably don't need to be putting together. Things that may lead to shortness of breath. Do we need to take a break? Have I gone on too long? Y'all okay? That's okay. I don't want to be torturing everybody. Just as long as it's only 1 or 2 people, it's okay. Not really. Okay, causes of shortness of breath. For your congestive heart failure patients, or actually any of your patients with shortness of breath, you want to first look at, do they have not first, but you want to determine if they have chest pain or not, because that may lead you down one track or another. Congestive heart failure, you may see edema. Remember, we talked about that as one of the things you're going to be looking for pretty quickly. Altered mental status. Why would they have an altered mental status if they have congestive heart failure? Poor perfusion. They're not getting enough oxygen, certainly to the brain. Crackling. Here we're talking about lung sounds. They got fluid in the lungs. Dyspnea. What's that? Dyspnea is difficulty breathing. Not necessarily shortness of breath. It's difficulty breathing. Orthopnea. What is that? Can't breathe when I lay down. Positional shortness of breath. Tachypnea, what's that? Fast breathing. And then anxiety, what would make them anxious? Yeah, can't breathe, lack of oxygen, I'm scared to death, certainly. Congestive heart failure, the heart is being weakened over time. They may have had multiple heart attacks, or they may have valvular disease, who knows. But with congestive heart failure, you're going to see a backup in the peripheral vessels. Okay? This is something you need to know because you're going to get a patient scenario on National Registry, and if they say they've got pedal edema, what bell is going to ring in your head? Yep, it's going to be right-sided heart failure, congestive heart failure. Usually when you're talking about congestive heart failure, you're looking at right-sided heart failure very commonly. Congestive heart failure also may indicate both sides are failing. Okay? So congestive heart failure, look for peripheral edema. If you see that, that should ring bells in your head. Assessment findings for congestive heart failure. All these we've already mentioned. Jugular vein distension. Why? The right ventricle is not evacuating the blood, so it's going to pool and stay in the right ventricle. Well, if blood is still returning from the rest of the body, it can't get in. It's going to back up. Where is it going to back up? It's going to back up from where it's draining in the head. That's going to give you jugular vein distension. And that's going to back up in the dependent areas in the body. If I'm standing up, what's my dependent area? Those things, yeah. Your ankles, your feet. If I'm laying down, where's it going to back up? Yeah, probably around the sacral area, the lowest point. You know, when you lay down, your butt's usually your lowest point, unless you got a big old head. Not really. Altered mental status because hypoxia, fatigue. Yeah, can't tire. I don't have enough oxygen. You know, I'm not getting enough blood flow. Dyspnea, orthopnea. Why is that a problem? When you're laying down, remember I showed you early on the Pepsi bottle? When you lay down, that fluid spreads throughout the whole section of the lung, and it's going to make it more difficult for you to breathe. Plus that pressure, that weight on your chest makes it a little bit more challenging. Chest pain, why might you have chest pain? Your heart's not getting enough oxygen either. Yeah, if it's not working, it's not going to be perfused well either. Pulmonary edema, fluid in the lungs. When do we see pulmonary edema? The first thing you're going to think about is left-sided heart failure. The first thing you're going to think about. But you can have pulmonary edema from a lot of different causes, but that's going to be what I'm going to be thinking about first. Okay, causes of shortness of breath. If you look around this little diagram here, just about anything can cause shortness of breath, but they're all pretty much heart or lung related. Pulmonary embolism. Let's go around here and tell me what you think might be one or two of the most common signs and symptoms that you would be looking for. All right, pneumonia. What are you going to see with pneumonia? What's going to separate it from other things? What's the chest pain going to feel like? Yeah, it's not. They're not going to say, you know, like an elephant on my chest. It's usually going to be pretty painful. It's going to be painful when they take a deep breath usually, and oftentimes, because this is an infection, oftentimes it's going to be associated with a fever. Now, if you have a patient that has a 98.6 temperature and they're showing signs and symptoms of pneumonia, could it be pneumonia even though they don't have a fever?
Yeah, it could have just happened.
Well, 98.6 may be a fever for them. Remember I said that they have a hard time controlling their body temperature. So they may be colder on a normal basis. You know, 97 may be their norm. So they've got a 98.6. That may be feverish for them. So just because it doesn't show a fever above 98.6, that doesn't mean that they're not feverish for them. But yeah, fever is usually one of the things, and then it hurts when they take a breath. Pulmonary embolism, what separates that? Is pneumonia an acute onset? Like 5 minutes ago? What about pulmonary embolism? Yeah, that's going to be acute. I was fine 5 minutes ago, now I can't breathe. What's the pain going to feel like? Sharp chest pain. Hurts worse when I take a breath, but this is going to be sharp chest pain, acute onset. What population do we see this commonly in? What are going to be your risk factors for pulmonary embolism? They have a blood pressure? Yeah, there are a few specific populations. Come on, y'all, put on your thinking caps. I'm not going to do all your thinking for you. Pulmonary embolism. Risk factors. Do what? You just throwing stuff out there, anything? I haven't eaten tonight, so I'm going to get a pulmonary embolism. Okay. It's possible. I'm looking for a couple of very important, significant things here. Populations of people or people that do specific things or have had specific things. Y'all are killing me. Huh? Lack of exercise. We'd all have pulmonary embolism. Good thinking. You're close. You're close. But I don't know if you realize. Why do pregnant women get pulmonary embolism?
Because of being bed bound.
What pregnant woman is bedbound? They're out there shopping and chasing kids. Are you kidding me? It's okay if I embarrass you. But you're almost there too. You're like Sarah. You're right on the cusp of discovering it. Y'all just not thinking. No?
People with plaque issues?
Like they haven't been to the dentist in a while?
No, not that part. Platelets, excuse me.
Platelet issue. Well, people with platelet issues, when you talk about the pregnant women are, well, late pregnancy, right around delivery, and then a few weeks after delivery, they do have a higher rate of pulmonary embolism because the body serves to start clotting because they don't want to bleed to death when they deliver the baby. So that's one of the actions of during the pregnancy is their clotting ability increases a little bit so they don't bleed to death. So yeah, they are more prone to pulmonary embolism. Okay, y'all just take 2 or 3 minutes and just look it up in your book.
I'm just confused on this.
Risk factors for pulmonary embolism.
Women on birth control, patients with cancer.
Okay.
Asthma,
Yep, that's it. Go ahead, keep going.
patients with low extremity injuries and injuries and injuries for a long period of time.
Yeah. Just remember I mentioned to you about what? I said that, that's what you're saying? Yeah, remember I said you take a long transatlantic flight or, you know, a coast-to-coast flight. Remember we talked about this? You need to get up and move around because as your body sits, your blood starts to separate. Now you're going to get clots. Remember I asked you guys if you've ever known anybody that's had a pulmonary embolism and died after having like a fractured leg or something. I think I told you I've known 2 or 3 people that that's happened to. Patients with cancer are more prone to pulmonary embolism. So if you get a patient, say they're, 30 years old, they've got acute chest pain, respiratory distress, it really hurts, you're going to start assessing for pulmonary embolism, right? What are the questions you're going to ask? Have you had recent surgery? Have you had a baby recently? Some guy, have you been bedbound? Have you just come off of a long flight? Yeah, so you're looking for pulmonary, risk factors. So yeah, y'all need to know these things. Remember I talked about those note cards? You need to be writing this stuff down because you're going to get a description of a patient and they're going to say, they're 30 years old, they've, have a acute onset of chest pain, they said they were coughing, and you're going to ask history, are you a smoker? Yeah, I smoke too much. Which one of these have we just described? Is it on there? Well, it's not on there.
A 30-year-old?
No, it's not on there. What would it be? 30 years old. You're thinking though. Come on. It's not on here.
Wait,
What's the same?
Okay. A young fellow, he says he's a heavy smoker. He was coughing, he feels like he's got some phlegm or something. He's had an acute onset of chest pain and respiratory distress. What's the history you want? What do you want to find out here? I mean, what are you thinking? Okay, because you suspect something, you start asking him questions and you start doing your assessment and you only hear breath sounds on one side. Huh? Yeah, spontaneous pneumothorax. Smokers, coughing, if they've got a weak area in their lungs, which oftentimes can be caused by smoking, and they cough, spontaneous pneumothorax. You've got to be able to hear these signs and symptoms, and you've got to be able to point them to something specific. Now, it may not be that, but you need to have a good index of suspicion based on the signs and symptoms that you hear. 90% of the time, you get a good set of signs and symptoms. You get a good history. You probably know what it is 90% of the time. But you got to be able to recognize them when you hear them and see them. Okay, y'all screwed that one up. We screwed that one up. Okay, how are we going to recognize a heart attack? I'll give you an easy one. Oh, do it. Chest pain. That's good. What other signs and symptoms? They may have indigestion. What'd you say, Elliot?
They might say pain radiates.
It may radiate to the left arm or both arms. Nausea and vomiting, yeah. They may have a history of heart problems, yeah. So you're going to look at a wide range of things. That can cause shortness of breath. So you can have somebody having a heart attack that their main thing is going to be shortness of breath. They may not present with much chest pain. It may just be indigestion. They've got shortness of breath. I mean, does a person that have indigestion when it's just like an acidy thing, are they going to have shortness of breath because of it? Probably not. Asthma? Wheezing may be a tip-off. What if they're like looking at you like that and they're not wheezing? Absence of wheezing oftentimes is worse than wheezing itself. At least when you're wheezing, you're still moving air. At some point, some of your asthmatics quit moving air and they don't wheeze anymore. So absence of wheezing can be really bad. Emphysema, congestive heart failure, chronic bronchitis, all of these things can lead to shortness of breath. So you got a patient whose report is shortness of breath. Now we're going to start narrowing it down. We're going to, what do we call that when we narrow it down? D. We're having a really bad night tonight, aren't we? The what? D. Differential diagnosis. Exactly. We're going to start narrowing it down based on the signs and symptoms, right? I mean, if the guy's 25 years old, are we looking for chronic bronchitis? Probably not. Are we looking for congestive heart failure? Probably not. Emphysema? Probably not. Pulmonary embolism? Now, that's one I'd rule in. Asthma? Possible. Heart attack? Probably not. Pneumonia? I'm going to have to get some lot better history before I'm going to bring pneumonia into this. And then, of course, spontaneous pneumothorax. I don't know why that one's not up here. So anyway, we were talking about pulmonary edema. Cause of pulmonary edema, congestive heart failure. What's AMI?
No, that's AMI. Acute myocardial.
Acute myocardial infarction. They may have valve damage. If they have positional dyspnea, then pulmonary edema is something I'm going to think about. Remember nocturnal dyspnea? Remember we talked about that? It's usually pulmonary edema. It's going to be fluid in the lungs. Your treatment, it's going to be the same treatment for just about any of these things. Oxygen. In this case, you want to make sure you sit them up. If you walk in and Granny's laying in bed, she's got one pillow behind her head, and she can't breathe and she's getting cyanotic, what are we going to do first? Sit her up. Now we can talk. But you got to get them in the position right up front. Pneumonia can cause shortness of breath too. It may be bacterial. It may be viral. We're not going to know the difference. We don't really care. Pneumonia is a secondary infection. So they already have something going on before they get pneumonia. I've broken 4 ribs. I can't breathe deep. I can't clear my lungs. It's going to get infected, that material that hangs around in there because you can't cough and clear it. If they already have a weakened immune system, it's more likely that they're going to develop pneumonia. Older patients very frequently will aspirate. It may just be food products, but they may vomit and aspirate. So if they have any history of that, if they're bedbound, if somebody's having to assist them in eating, then they're more likely to have aspiration issues. Pulmonary pneumonia, increased respiratory rate, increased difficulty breathing on exertion. They may have congestion in the lungs, possible fever. They may have chills, probably feel very weak. Younger people can have pneumonia too, but it's very common. I think it's the 4th leading cause of death in the elderly population. Treatment's going to be the same. Almost anybody is going to breathe better sitting up. So you're never wrong to sit them up. COPD, which is going to be typically chronic bronchitis and emphysema, right? In these cases, there's a gradual change. That's why we call it chronic COPD. Respiratory distress, increased work of breathing, treatment. If they have an inhaler, then you want to use that. But position them, and you may have to bag them sometimes. Chest pain. A lot of your elderly patients may have a silent heart attack. Which group of people are we going to see more silent heart attacks? Do what? It may not be silent, it's just atypical. We'll talk about that. That's a good guess. I've told you guys this, you've probably forgotten. Because you've forgotten everything I've told you already. Anybody? I've told you this specifically. I'll tell you again. Diabetics very frequently have silent heart attacks. Remember what I told you about sugar? It's what? Necrotic. It kills a lot of the nervous system. They don't feel this. So with your diabetic patients, they're not reporting they have chest pain. What are you going to be looking for? They don't have chest pain. So what are you going to look for? What's going to be the second thing that they're going to have? Respiratory distress, right, shortness of breath. And so being not having chest pain is what, DD? Pertinent negative. I'm sorry, I screwed myself up there. So pertinent negative. So you want to make sure you get that information. So yeah, with silent heart attack, very frequently they're diabetics, but any of your patients could suffer from no chest pain. General complaints they may have, instead of specifically saying it feels like an elephant on my chest, they're tired, they have respiratory distress, they may be nauseated. Chest pain patients very frequently vomit. It's very disturbing for me. Syncope, what's that?
No,
Done fell out. Yeah, they faint. Respiratory distress, indigestion. Sometimes their shoulders ache. The shoulder blades. Between the shoulder blades, they'll say that it hurts. Women in particular. Women in particular have what we call atypical chest pain. I think we've talked about this. And they may just report back pain rather than chest pain. In fact, back pain is their most common complaint for a heart attack. Treatment, if they have nitroglycerin, you may give that. What are you going to be specifically wary about with nitro? Blood pressure. Yeah, what else have you taken? Any erectile dysfunction? You're going to give them oxygen, nitro, aspirin, and transport. Of course, you're going to have to call for orders. Altered mental status. What does that have to do with altered mental status? Is altered mental status in the elderly, is it acute or chronic? Yeah, it could be either. It's important that you find out if it's acute or if it's chronic. All right, that was good. Sorry, got to work on that one, I guess. Patients may have an increase or decrease in hormones. They may have a release of hormones that raises their blood pressure. What other things causes their blood pressure to rise? Stress, just being old is stressful. They're anxious, that's possible. What's something that they can't really control at this point that could cause high blood pressure? Yeah, their blood vessels, yeah. They lose that elasticity, right? Remember atherosclerosis, arterial sclerosis, remember those two? Those can cause an increasing in blood pressure. But yeah, if the vessels have lost their ability to expand and contract so that they can't expand to move that big pulse along, then it's going to cause hypertension. They may have fluid imbalances. Drop in responsiveness to insulin. What exactly is this? Yeah, if I may use this as a definition, just about. With this definition, you would say this, what would you, if it was like matching, what would you match this to? Type 2 diabetes, exactly. Type 2 diabetes, they probably are releasing the same amount of insulin, but the body, the cells become resistant to the insulin. So they have a drop in responsiveness to insulin. That is typical of type 2 diabetes. They may become carbohydrate intolerance. I hope I never get that because I love my carbs. Elevated blood sugar levels because of why? Yeah, unresponsive or intolerant or unresponsive to insulin. So if they don't have the insulin then that properly moves the sugar into the cells, then they're going to have higher blood sugar levels. Stroke, what are the signs and symptoms of stroke? Facial droop. Yeah, what do we call that? We're going to check the three things? The Cincinnati Stroke Scale. What are the three things you're looking for? Facial droop, pronator droop, and what? Speech. That's right, those three things, so make sure you look for those. So what are the other things you're going to assess for besides doing the Cincinnati Stroke Scale? Check the pupils, exactly. What all patients should you check pupils on?
All medical.
Everybody, check the pupils. Yeah. Okay, what else? What would be some other signs and symptoms you want to check if you're trying to assess for whether a patient had a stroke? Yeah, do they have a headache? Are they hypertensive? If they've got the worst headache I've ever had in my life, what are you thinking? What kind of stroke? Hemorrhagic stroke, yeah. What's the percentage of patients that have a hemorrhagic stroke? About 20%. Which one's worse? The hemorrhagic stroke, that's correct. So what would be the other signs that might be associated, say, with a ischemic stroke? What did you say, Bo? That would be a TIA. A TIA goes away. Transient is what that means. Okay, so what other things might your patient report? Who has a band around their head? If the patient says it feels like I have a band, constricting band on my head, what are you thinking? Carbon monoxide. You've got to be able to associate those different things. But that's good. What else? But that's not right. But
Probably a more rapid onset ratio when talking and build up the muscle community.
For the stroke patient, it would be an acute onset. Nausea and vomiting. They usually are nauseated. They very frequently vomit. What other things might be a stroke that might not be like weak on one side or a blown pupil? They may have some memory losses. What other things there? Like? Yeah, we see that. We probably look for that more commonly with a head injury. But remember some of the things I've talked to you about, that they may have some form of speech issues where they understand, but they can't get it out, or their speech is impaired, or the brain is twisted around, or it may be hearing deficits. I can hear out of one ear, not the other. Visual disturbances. All of those may be associated with a stroke. Too. Let's see what all we got. Pupils, slurred speech, headache, memory disorders, alterations in respiratory pattern. If they've got alterations in respiratory pattern, what are we looking at? Looking at severe FTD. This is going to be a very low clot close to the brainstem, right? That's where our respiratory center is. Heart rate abnormalities, high blood pressure. It may become normal, may drop, it may jump around. Seizure is very common with strokes. Muscle weakness, paralysis, sensory loss. Yeah, so when you're doing your assessment, you got to make sure you assess for all these things so you can do your differential diagnosis. TIA, remember, is a mini stroke. What separates it from a real stroke? What's the time frame? It will clear up in less than 24 hours. It usually clears up how fast? Within about 10 or 15 minutes. You got a temporary blockage of blood flow to the brain. Temporary. Right? So how is this usually fixed? Huh? It resolves itself. The body has its own built-in way of dissolving these little clots. And as long as they're little and the body's working good, it may be able to dissolve that clot. But as the clots get bigger, it won't be able to dissolve that and may become permanent. So usually you've got little bitty clots that the body's own mechanisms will clear it. Seizure. Patients that have had a seizure, there can be a lot of causes from that. Low blood sugar, it could be cardiac in nature. It could be a patient that's had a stroke, so they've had a seizure. It could be electrolyte imbalance, tumors, all sorts of things. Your care is going to be the same. Oxygen. At which point are you going to ventilate a patient? When the rate and volume is not sufficient. When they're breathing inadequately. Trying to determine their chief complaint, it can be a really big problem. I said this before, talk to the patient, not about the patient. If the daughter's there, don't just talk to the daughter, talk to the patient until you determine they're not able to give you a good answer. Alright, how are we doing? Who's watching the slides here? Now a lot of your patients are just going to feel dizzy, they're going to feel weak. What does this word mean? Malaise? That's not really. Malaise is where you just generally feel like crap. You know, you feel weak, you feel tired, you feel yucky, you don't want to do anything. There's a large part of this word also is mental. I just can't do it. I just can't do it. I just feel like crap. So if they have a mild or general complaint, that doesn't mean nothing's wrong. If I'm assessing one of you guys, you're 22 years old, and you say, I just don't feel right, I'm going, you're faking. But your older patients, when they don't feel right, they cannot define it any more closely. It can be life-threatening. They can deteriorate very quickly. Do a very good assessment. Get as much history as you can and do a good assessment. Talked about depression and suicide. It's very common in your elderly patients for a lot of different reasons. I can't get around anymore. I'm in this chair. You know, I used to be an athlete. You know, I used to do all this stuff. Now I can't get out of my daggum chair because my knees have rotted away. They may take medications that slow them down. You know, if you've got patients that are taking beta blockers for their heart, Their heart rate just doesn't get as fast as it used to. You know, the medication is designed to slow everything down, so they feel really slowed down. They have no energy. It could be a blood sugar issue. You know, they're depressed. They're, you know, they don't have any friends anymore. They've all died. Watch for other things too. I know there have been some ads on television about shingles. That's really creepy. So you may have patients that have shingles, which you want to make sure you have your gloves on. You don't want to catch that. It's a virus that they have acquired when they got chicken pox when they were young, and it represents itself later in, well, not even necessarily later in life, but it goes along nerve tracts, and it's extremely painful, and it's almost like a rashy thing. It may have little pustules on there, and they may break. It's extremely painful. You usually see it in the moisture areas, but it may be around the neck through here, and like the slide says, it may be around the torso. This is what you want to notice. You can contract it from the fluid, so nay, stay away. So it's kind of sick old picture of it around the chest, just like it says. You'll always be looking for shock, whether you've got a trauma patient or a medical patient with your elderly. They just can't tolerate the blood loss and the hypoxia that comes with that. Now, if you have an elderly patient and you get called for with altered mental status, can you automatically rule out a trauma? They may have fallen and they don't even remember it. They may have had a very small insult that for you, I mean, if you bang your head on a cabinet, it's nothing. They bang their head on the cabinet, they didn't even fall, and they can have a slow bleed in there. So don't rule out trauma just because you can't see anything. But a lot of things can cause those traumatic injuries. It's not uncommon for them to feel dizzy. Remember earlier when we talked about a patient that's fallen, besides finding out the things like what have they hit, how far did they fall, you want to find out what made them fall. Did they slip and fall? Did they lose their footing? Did they get dizzy and fall? Did they have a seizure and fall? You know, what's going on there? You need to get all of that information. For your elderly patient, half of all accidental deaths are due to falls. Head injuries are harder to detect. Usually they're a little bit slower bleed. It just kind of accumulates. But if it's a slow onset, you may not recognize the altered mental status. And if they're not there to tell you, you may miss. I mean, if somebody's not there to tell you that they're not like that, you know, if you suddenly had an acute altered mental status, then I would start looking at all these different things. But for an elderly person that over the last 2 weeks, they've had a slow deterioration. If they're 95 years old and they've had a slow mental deterioration, what are you thinking? It's your time, you're losing it. But it could be a bleed, so make sure you consider that. You'll spinal package your elderly patients, but just make sure that you are very attentive to padding things well. They may have a decreased sensitivity. Look at mechanism of injury. Just as we consider mechanism of injury for kids, we call that a little bit tighter than we do for adults. Same thing with your elderly patients. You know, a fall from a standing position can be a severe injury for them, whereas if you tripped and fell here, I'm not looking for any severe injury. It's not a severe mechanism of injury. Make sure you do a complete exam, get your baseline vitals. Recognize that they deteriorate very rapidly. So don't waste any time. As we said, half of accidental deaths in the elderly are due to falls. If they're seen in the emergency department because of a fall, there's a good chance that they're not going to survive the year. I mean, the stats on the number of deaths, I think 25% of elderly patients that are seen in the emergency department for a fall will pass away within that year. That's probably all they've documented. Why do you think that's the case? They what? Probably fall again. Why are they falling? Yeah, when you look at why they fell, you know, is it a lack of mobility? Is it they have a heart condition? They have syncope? You know, they got blood sugar issues. So they've got all these issues that may lead to their fall. So it's not the fall itself that kills them. It's the conditions that lead to the fall that kills them. So falls indicate a lot of underlying issues. So if you can figure those out, that's real helpful. You know, if they're real shocky, they may fall. They pass out and fall. So you want to treat them for the fall, those injuries, but you also want to look at those underlying issues that may have caused the fall. Osteoporosis is going to be mineral loss. Y'all know that. Kyphosis, you need to know this word. It's going to be curvature of the spine. So a lot of your patients have kyphosis. I probably should have said that earlier when we were talking. It also causes decreased joint flexibility. You know, they just can't move well. You know, all of a sudden some dog jumps out at them, you know, jumps through the fence or something. They can't move that quick. So as they try to move quickly, they may fall and hurt themselves. You also got to look at abuse and neglect. We talked about it very briefly in pediatrics. We're going to talk about it more next week. But we see a great increase in elderly abuse. So you need to keep your eyes and ears open for that.
She looks so sweet.
It looks just like Tim's grandmother.
Well, she did honest.
She what?
Grandmother's alive too?
No, but I would swear that was Nana. They've used this picture in this textbook for 15 years, so it might have been her. I wonder if she signed a release for that. Anyway, there are several different types of abuse. You know, we think of physical abuse, you know, that somebody's being hurt. But with the elder, we also see mental abuse. We also see financial abuse. You know what financial abuse would be?
The kids taking all the money.
Yeah, you know, you get the son that gets over there every month and grabs a Social Security check. Fortunately, now they do direct deposit, so he just goes down to the bank and withdraws the money. So yeah, there's a lot of ways that they can be abused. We see it commonly in patients that are bedridden or, you know, have a lot of physical issues where people have to take care of them. The things to look for, a lot of bruising. Bruising may be perfectly normal. I mean, where just the process of them being alive and moving around, they're going to get bruises sometimes, but they're not going to get bite marks. But have you ever seen bite marks on a patient, an elderly patient? It shocks me that anybody would bite somebody. The last thing I want to do is bite anybody. That just really freaks me out. But yeah, I've seen it too. It's like, who in the world would do that? Bite somebody. Trauma to the ears, you know, big plugs out of the hair, you know, where they'll grab their hair and just pull it like that. Broken bones, cigarette burns, rope marks. It's not uncommon for a person that's being abused like this where they're restrained in a unhumane way. You know, in the ambulance, we've got posing, we've got nice soft restraints. When they're restraining in a home environment, sometimes they're not so nice about it. So you need to start looking for these things because you need to report it. If you see somebody living in conditions that are not good, you need to report that at the emergency department. It's required reporting also, but you've got to have your eyes and ears open and you need to be looking for it. Environmental extremes, is that what we're talking about? I told you that they don't auto-regulate very well, so or thermoregulate. So be alert to too hot, too cold. They may not even recognize it. They're susceptible to hypothermia. We already talked about why that is. Talked about all these things. Drug toxicity, we've talked about this. Approximately 1/3 of all prescription medications are taken by your elderly patients. They also buy a lot of over-the-counter medications. And over-the-counter medications frequently don't work well, don't play well with prescription medications. So be alert for that. Know that they often have coexisting diseases. They got a lot of things going on. Have y'all, on some of your clinicals, have you seen patients that have, I'm a diabetic, I've got COPD, you know, I've got this, I've got that, arthritis, whatnot? When you are caring for your elderly patients, recognize that they're not in a place that they want to be. You know, they used to be your age. They were running the streets too, and now they're, you know, 95 and they're confined to a wheelchair. So remember, there but by the grace of God go I, and know that, you know, you might be there in 50 years and hope that whoever's responding is going to care for you in a compassionate way. So treat them with dignity, be kind, don't blow them off, don't be rude. Do what you can to help them. If you're transporting them, you know, they may have a little dog at their house that somebody needs to take care of, or, you know, make sure you lock up the house for them, do whatever it is they need if you've got the time for you to do that. Just any elderly person, think of it as one of your family members, you know, your grandmother or some of your cases your great-great-grandmother. Be reassuring and be empathetic. Sometimes they're just lonely and they need somebody to talk to. That's part of it. I think we talked about dementia and delirium. Have we talked about the differences here? I guess not. Dementia is malfunctioning of normal brain activity. It's chronic and it's irreversible. That's dementia. Okay? You can't fix that. Delirium, on the other hand, is an acute onset and can be caused by a lot of different things. But anything with an acute onset, you've got to be able to recognize what's normal and what's not normal. How was the patient last week over how they are today? So with delirium, that's how you're going to recognize that, is determining if it's acute or if they've been like this. Delirium, we'll see with alcohol withdrawal. What do we call that? Remember? The DTs, that's right. What are the signs and symptoms of DTs?
Nausea,
Hallucinations, altered mental status, seizure, anything else? Hallucination is probably the one that you're going to set aside, but seizure is very common. Psychiatric disorders can lead to delirium. They're using sedatives. If they're malnourished, infections, hypoxia. See, hypoxia is going to be an acute onset, well, maybe not, which can cause a severely altered mental status. Endocrine disorders, fever, a lot of things can give them an altered mental status. That is not dementia. Dementia is chronic, altered mental status that is acute. Sometimes we'll call it delirium. Alzheimer's disease, what, I lose something here? I don't know. Can't remember what I had there. Signs and symptoms of Alzheimer's. Usually they're going to have a diagnosis, you hope. But since this is a chronic disorder with a slower degeneration, they may be confused, and that may be the first thing that you notice. The patient's confused. They may be depressed. They may be violent. They have lucid periods where they may appear normal and they think normally, and then they'll have a very violent or irritable spell after that. Your care, compassion. Recognize that if they are very irritable or cranky or aggressive, they can't help it. It's just like a patient with a head injury. You know, if they're hypoxic from a head injury, they may not be able to help the way they're responding. Y'all go through these when you're working on studying here. Chapter review. Just because they're older, don't automatically pigeonhole them and say, well, they've got dementia, or they've got this, they've got that. You can have extremely healthy patients that are extremely old. You can have young people with altered mental status. Don't just automatically assume because they're old they've got all these bad things. Look at them as individuals. Be alert to medication issues. You know, what the medication, the impact of medication on your patient. Watch for signs of elder abuse. Okay, you're called to the nursing facility for an 85-year-old female who is having trouble breathing and is very confused. What do you suspect may be wrong with this patient? What actions would you take in treating this patient? So difficulty breathing and is very confused. That's one of the first things you want to find out. Yeah, her normal mental status, certainly. Do I have the answers up here? No. Okay. What do you suspect may be wrong with this patient? She's got respiratory distress. You remember all those things on the wheel? Yes. Oftentimes that altered mental status is due to hypoxia. The cause of the hypoxia is going to be for you to try to find out. What actions would you take in treating this patient? Oxygen. That may fix your patient. It's the first thing you're going to think of. Y'all know who that is? Granny. Yeah.
She was so funny.
She was pretty funny. Hey, y'all take a break, and I'm going to have to go down and get the other chapter because I didn't load it to the drive.